Hello, everybody. Welcome to the New York Medical College Intergenerational Chapter of the Benjamin Rush Institute. We're here to hear a talk by Dr. Forcht Dagi. Before we start, I want to give a sincere and grateful thank you to Dr. Peter Bedavenia, Tara Alfano, and Rebecca Kiessling. Peter is an alum of New York Medical College class of 1985. And when he came to New York Medical College and spoke to Tara and I about creating a program or creating a community for New York Medical College that would not only provide mentorship for students, but can look to create a community that incorporated students, faculty, administration, and the alumni communities, that we can all learn from each other, and we can learn in such a way that wasn't only a matter of clinical expertise, but professionality, understanding the patient-clinician relationship, and understanding the profession of medicine and how the profession of medicine relates to society and economics. New York Medical College was very excited about it. The opportunity to create such a community, and working with Rebecca Kiessling, who's the director of programs at the Benjamin Rush Institute, and Tara Alfano, who's the director of alumni relations, really allowed us to create this unique opportunity at New York Medical College, which hopefully will serve as a model for other medical colleges around the country. In order to get started, I want to introduce Dr. Forcht Dagi. Dr. Forcht Dagi is a friend who is a very accomplished physician, very accomplished academic, I would just say a very accomplished person at large. He was the chairman of the medical school at Queen's University, Belfast for over a decade, where he was involved in establishing 4 research and 3 educational centers along the NIH model. And he brought the university to the Russell 20, which is a group of top research institutions in the UK. He was a professor at the William J. Clinton Leadership Institute at Belfast. He's an international surgical advisor with the Royal College of Surgeons in Edinburgh. He's the director of the American Association for Neurological Surgeons. He's the editor of Neurosurgery and the Journal of Clinical Ethics. He's a consultant for the Mayo Medical School and others. And he's also been involved in 4 venture capital funds, a major venture philanthropy fund, and more than 30 public and private boards in the US and Europe. If I was going to say one sentence about Dr. Dagi, I would say that Dr. Dagi truly encompasses what it means to be a Renaissance person, where he has mastered the art of medicine, mastered the art of the humanities, as well as mastered the practical wisdom of being a man of virtue and excellence in society. So with that, I'm going to mute myself and leave Dr. Dagi to give the presentation on, is it possible to be an entrepreneurial professional in healthcare? So Dr. Dagi.
Well, Dr. Bezos, thank you very much for the invitation to speak tonight. And thank you very much to Ms. Alfana, to Ms. Kiessling, to Dr. Bedavenia for making this all possible. And thank all of you who are here for taking a chance and spending a Tuesday night listening to a rather arcane topic. I hope you have fun with this tonight. I hope to tell you a story. And the story is about the various sides of medicine, how we came to be physicians in the common mold, how it is that medicine has some of the cultural biases that it now has, what it means to be an entrepreneur in medicine, whether it's acceptable, whether it's a problem, what to do with it, and some things perhaps to think about in your career. So what I would like to talk about is how one can become an entrepreneurial professional in healthcare. And really that has a series of different parts to it. One part of it is how to become an entrepreneurial professional in healthcare. What do you actually have to do? How do you make this happen? Is it possible? Do people succeed? The third is, how do you succeed? What do you need to do? The next question is whether it's permissible, because there are a lot of people that would say entrepreneurship on the one hand, being a healthcare professional on the other, maybe they don't quite fit. The next is how to stay true to your principles while becoming an entrepreneurial professional in healthcare. The very fact that as I sit here, I have to tell you about my disclosures and about conflicts of interests suggests that there's some pretty difficult standards that have to be met, both in being a professional and in being an entrepreneurial professional. And the last thing is entrepreneurship in medicine a good thing? Well, on the bottom, you can just see some names of companies that have done an awful lot. Amgen, arguably the first of the modern biotechnology companies. DaVita, a company that has done a lot in kidney dialysis, but also in analytics to figure out what to do with different patient populations. Moderna, that you've all heard of because they're one of the 28 companies, maybe 29 today, that's about ready to come up with a vaccine for COVID-19. Medtronic is a neurosurgical company, does a lot of electrodes, does pacemakers. It also is a diabetes company. Masimo, which is oximetry, without which the whole COVID-19 epidemic could not have been well handled. And Optum and United Healthcare that are really medical informatics companies. So there's a technical and there's a moral side to what we're talking about. Technically, there are a few questions. What does it mean to be an entrepreneur? What is entrepreneurship? What does it mean to be an entrepreneur in healthcare and the life sciences? How do you do that? But there's a moral part, and I'd like to talk about both. Isn't entrepreneurship about money and profits? Isn't medicine supposed to be philanthropic? Aren't physicians and scientists supposed to be altruistic? Isn't entrepreneurship exactly the opposite? Where is the moral purpose in what we're doing? And so another way of asking the question is whether entrepreneurship is in some way inimical to medicine. Well, I don't think so. And I'd like to show you the reason why I don't think so. What's an entrepreneur? If you look it up and you look in a library or you look online, you'll see a million slides, you'll see a million ideas, and some of the words that come across are independence, leadership, innovation, ventures, businesses, risk management, opportunities, courage, ideas, and finally the idea of a business. But the words actually have specific meanings. An entrepreneur comes from French. It means to try. So a person who organizes and operates the business or businesses, taking on greater than normal financial risks in order to do so, that's an entrepreneur. Also a person who's an organizer, who manages an enterprise, especially a business, usually with considerable initiative and risk. Then there's a definition that says, an entrepreneur is a person focused on building and growing an enterprise, whether it's a brand new business or transforming an existing company through innovation and making the most of opportunities that are hidden to others. So an entrepreneur is a prospector, believes what she or he does. And then there's my favorite that comes out of Harvard Business School that says an entrepreneur is somebody who pursues opportunities beyond the resources that he or she controls. So it's outside of the ambit of what that individual has. So this sounds pretty innocuous, pretty safe. Where's the problem? Well, the problem has to do with the fact that entrepreneurship speaks to profits, and profits are a two-edged sword. The reward of entrepreneurship is typically denominated in terms of growth and profits. Profit can be defined as a pecuniary, so a monetary gain, derived from the difference between financial gains that an enterprise or a company enjoys and the expenditures required to earn them. So it's been pointed out that you can sell a case of Coca-Cola at 5 cents a can all day, but you won't make any money doing it because the cans cost 10 cents a day. There has to be a difference between the gains and the expenditures required to earn them. You can have profits from a service, that's what most physicians do, or products, that's what pharmacists do. From sales or distributions, that's what pharmaceutical companies do. profits from the growth of a company. That's what happens if you build a biotech company and you expect it to grow as you have more products. It could also be from the private or public sale of a company. That's what happens when a company goes public. It's an historically uncomfortable topic within medicine, arguably all the professions. It doesn't fully capture what entrepreneurship is about. So here's a little curiosity. It turns out that in England, everything is denominated in terms of pounds and pence, with two exceptions: antiques and medicine. Medicine is denominated in terms of guineas, and a guinea is a pound and a shilling, so about 20 pence. And nobody quite knows why that is, except that it was a little bit more aristocratic not to put things in the same financial terms as buying fruits and vegetables. Well, why is it uncomfortable? To explore that, we have to think about the meaning of profit, specifically the moral meaning of profit. So profit ultimately represents the amount that a customer knowingly provides a company or an entrepreneur for the value they have received above that company's cost. There's a second definition. It ultimately represents the amount that a company receives above its cost to the disadvantage of its customers and without their knowledge. If you know the definition of a public utility like water or power is limited in its profits to the marginal cost of production, so the cost of producing the product or the service when it's fully efficient, plus some percentage that is being allowed. Medicine doesn't have that yet. There are many people who would like to do that. But the question is, what is the marginal cost of producing medicine? Well, the second definition is very important because it reflects views of capitalism. And there are two different views of capitalism. One, we just alluded to. Profits are a reward for good service and good products, and therefore a measure of value and reward for work well done. You may know the famous Yogi Berra, the famous Yogi Berraism. Nobody goes there anymore. It's too busy. Well, if it's busy, that's a good thing. What you don't want is a place where nobody goes. But the other side is a view that says profits can only be achieved by cheating people, by exploitation. Exploitation is to be avoided. If everybody were paid the same, everybody had the same, you wouldn't have to worry about profits, and you'd live in a much different, much more moral society. And remember this in terms of a venerable, age-old proverb: a rolling stone gathers no moss. How you interpret that depends entirely on the way you feel about moss. If you think moss is a good thing, then you don't want to roll. If you think moss is a bad thing, then you do want to roll. And so people finish the sentence by saying, a rolling stone gathers no moss, but it can acquire a certain polish. And that more or less captures the problem or the controversy around profit. Is profit a polish, or is it something else? Well, why is this a problem? I've got to tell you a little bit about the history of medicine and profits and what medicine is. And I've got to go fairly far back. I've really got to go back to the Greeks. There's a fundamental principle that most people agree with, I certainly do, that medicine should be a virtuous and a noble profession, and people who practice medicine are and should be virtuous and noble people. Here's a famous picture from a collection of the Wellcome Institute of the doctor as an angel. I warn you that there are three other pictures in this series: the doctor as the devil, the doctor as a flawed human being, and also the doctor as God. So how do you practice medicine virtuously? Number one, you focus on social benefit and not profit. That has moral, political, and social imperatives. Number two, you believe that concentration on wealth and on profit is crass and corrupt. Number 3, we do not profit from illness and misfortune. Number 4, we want to live in a society which has risen above the profit motive. If any of you like to read medicine or the literature of medicine, one of the most interesting people to read is A.J. Cronin, who wrote Around the Coal Mines of Wales in the late 1930s, when England was really in the depth of the Depression. And there's a film called Citadel. It's also a book. And the point of the film is that truly virtuous physicians are not happy making money alone and will give up money, will pay, in other words, as the economist would say, for the privilege of practicing virtuously. It's an old film and it's corny, but it's worth seeing just to get that idea. This, by the way, is The Doctor is the Devil, same artist, Egbert von Panderen in 1609. In 19th century Europe, the welfare state emerged. It became a benevolent society in theory. Modern poor laws developed, and there was protection of labor. Eventually, there was protection of children too, but that came a lot later. And interestingly enough, the protection of children came not out of a sense of virtue, but a sense of the protection of working animals. Bismarck, in the late 19th century in Germany, introduced the idea of effectively free healthcare. Several social welfare models emerged. There was one in Germany, one in England, different ones in Scandinavia, different ones in other parts of the world. The NHS, the National Health Service in the UK, is the most familiar to Americans. Well, I trained both in Boston and in England, and I cannot tell you how many times at lunch doctors complained 40 years after the institution of the National Health Service that since linen tablecloths were removed from the dining room, medicine has not been the same. The doctor's dining room is a critical privilege, and the NHS, in democratizing medicine, took away some of the most important parts of the practice of medicine in England. In any event, the benevolent society would argue, as many would today in the United States, that healthcare should be a guaranteed, affordable right, open to all. If you accept these principles, and if you accept this history from the purest social democrat perspective, the profit motive in medicine, whether through pharmaceuticals or devices, whether through surgery, or whether through other services, is inherently immoral. QED, I don't need to show you anything else. End of talk. The picture, by the way, on the right is a picture of the health card in the EU, which lets me with an EU passport travel any place in Europe and be sure that I can get health care for free. Well, how about the US? Aren't there any advantages to the US, to capitalism, and the free enterprise system? Well, many people who left Europe to come to the United States and to escape socialism and communism would say, yeah, the system doesn't work. In fact, there's a great joke that says, what's really the difference between socialism and capitalism? And the idealist would say, well, the trouble with capitalism is that man exploits man. Well, what about socialism? Socialism is exactly the opposite. So let's look at capitalism for a second. And I'm not speaking politically now, I'm speaking economically and historically. Capitalism is defined as an economic system based on economic freedom, voluntary willing exchange of goods and services, private property rights, the profit motive, and competition. And this came from John Locke, who, by the way, was a physician. A free enterprise economy, which is what we aspire to in the United States, has 5 important characteristics. And they are the economic freedom we alluded to, the willing voluntary exchange, or trade of goods and services, ownership rights, which are critical, the profit motive, which is celebrated, and again, competition. Now, what do you think about this? Do you think this is immoral and amoral? Well, capitalism is under critique, and it has been since Marx and even before that, in the mid-19th century. Number one, capitalism is said to be inherently exploitative and unfair. If I make my money from labor and I can pay labor less, I can have higher profits. We don't like that. That's unfair. It's unsustainable because sooner or later, workers will rebel. It results in economic inequality, racial disparities, other forms of injustice. Well, we're in the middle of talking about that in the United States today. There's several questions that can be asked. Is the word result the right word? Does it occasion? And is it possible to have the same system work without these inequalities? It's anti-democratic. It doesn't preserve, it erodes human rights and dignities because you have people who have and people who don't. It incentivizes historically regrettable, reprehensible events like war, like imperialism, and it intersects with a critique of profit and entrepreneurship. Everything that's wrong with capitalism is wrong about profit and entrepreneurism, and vice versa. Well, this is one of the many cartoons, if you look, you'll find about what capitalism and socialism are about. You see that capitalism and socialism are different, but they're very similar. You'll find that fascism is defined as treading down people. You'll see that anarchy is defined as glorious. You'll see that socialism is defined as shooting a person with money. And capitalism, described by socialists, is described as shooting somebody with money. So the definitions are perhaps not that clear. But I'd like to focus on one question. I'm assuming that everybody who's sitting around the computer and in this virtual room is a moral professional. Must moral professionals oppose profit? Is there any way to do both? Well, to get there, to get to an answer, we must talk about the history of the professions. What is a profession? What is a professional? So a little bit of history and a little bit of etymology. A paid occupation requiring specific training and qualification is defined as a profession. It's a little different than a trade. It's a couple of levels higher. Some people would argue that the traditional guilds could just as well be described as groups of professionals. There really are differences, but maybe this isn't the place to talk about it. The next part, which is etymologically, though, is important. From Middle English, professional denotes the vow made on entering a religious order. It comes from French, from Latin, and it says to profess or to declare publicly. And it derives from the notion of an occupation that one professes to be skilled in. It's a public declaration, and what goes along with that is the valence of a profession. Valence is more than meaning. Valence is what goes along with it. So the term professional has come to mean to have or to claim knowledge or skill in our case, medicine, to affirm one's faith or allegiance, maybe to a religion or set of beliefs, maybe to a moral code. And to be professed is to be received into a religious order under vows. This is a sketch of King Alfred teaching English, or at least English being taught in his court, very early on before the invasion of England. And there's one person who's capable of reading, and that individual is the teacher. He's dressed differently. He has professed. Others sit at his feet and learn. The medical profession was a moral elite. The Hippocratic Oath, which we all know, is often said to be a common document. In fact, A very famous historian, Ludwig Edelstein, showed that that is really not true. The Hippocratic Oath was a Pythagorean document, very elitist. The whole idea of your teachers being holy to you, of there's certain things you would do and you wouldn't do, ways in which you were paid and ways you wish you wouldn't be paid. These are ideas that not everybody accepted. In the early Middle Ages, medicine was often practiced as a religious charity. It was certainly a calling, and it was followed by clergy in the West. There was no remuneration. It turned out in the late Middle Ages that a monk asked shelter from Bernard of Clairvaux, a Cistercian, because his practice of medicine was intended for the financial gain at a monastery. He was granted shelter. The Lateran Council of 1139, one of the great Catholic congregations, said that monks and canons are not to study jurisprudence and medicine for the sake of temporal gain. The care of souls being neglected, that they promised health in return for detestable money, and thus make themselves physicians of human bodies, is terrible. They ought to care for the souls only, not the bodies. The Fourth Lateran Council, about 85 years later, said something different. It is licit or allowable to receive remuneration for what one is not bound to do gratuitously. Moral theologians went on to discuss many moral aspects of medical fees. The basic principle was that one could only impose a reasonable fee, and it was determined by the quality of care, physician's labor, diligence, and conscientiousness. Also the custom of the place, today we call that reasonable and customary fees, and the patient's means. It was taken for granted that certain patients would neither be charged nor pay. There was a tradition that developed. Self-righteously, physician eschewed open profit. But broad professional codes did not develop until the profession organized in the 19th century. And because of that, even though these existed as religious and moral principles, they really didn't go very far. Something changed with the advent of the Reformation, with Luther in the 16th century. Whatever else can be said about the Reformation as a religious movement, it was a critical economic movement as well. It led to the creation of a centralized state. There was a temporal rather than a spiritual power and authority. By temporal, I meant a duke and not a bishop. It stimulated a money economy, not a trade economy. And profit was not only no longer necessarily disdained, it was sought. And here is Luther before the Diet of Worms in 1521, condemned for suggesting that the temporal authority take precedence. In modern 19th century Europe transformed. It actually transformed in the last quarter of the 18th century with the French Revolution, shown in the slide to the right below. Economics, politics, philosophy, social structure, all different. More important to what we're talking about than the revolution was the idea of putting knowledge in the vernacular where people could reach it. Not the first modern encyclopedia, but Diderot's encyclopedia, his systematic dictionary of science, arts, and the trades, democratized knowledge. A picture for how to work with wood below on the left. It was a major stimulus for advances in science and technology. And science and medicine flourished disruptively, beginning the end of the 18th century. And that's shown, it's reflected in the rise of American medicine between 1850 and 1975. In the mid-19th century, physicians, other than those who went from Philadelphia or Boston mostly, to Paris or to Edinburgh or to London, had little status and training with a very wide range of incomes. There were several schools of practice: conventional, homeopathic, eclectic, osteopathic. And as a result, the AMA formed in 1847 in order to impose standards for training and qualification and membership in the profession. Remember, we talked about that? You had to be admitted. There was a new emphasis on medical science and not just practice. And there were codes of ethics that included obligations to care for the needy and the indigent. Below is a slide of snake oil liniment. If you've ever heard of a snake oil salesman, it relieves instantaneously all kinds of things, many of which you have and many of which you don't. There were tremendous concomitant advances in the medical sciences, mostly in the first 3 quarters of the 20th century, but also at the end of the 19th. Basic science, antibiotics, anesthetic techniques, and surgery. Huge, grand, university-related medical centers. Intensive care, cardiology, neurosurgery, which didn't really exist prior to 1905, war surgery. Technology that led to vaccines, transplantations, bioengineering, biomaterials, and informatics. And this was a great moral enterprise. To your left, you see a picture of penicillin and what it does to bacteria. To the right, you see why people weren't so sure about the morality in antibiotics. It's okay that penicillin cures gonorrhea, but do you really want people to stop worrying about getting gonorrhea? Not so sure that was a good idea. In any event, the government became the largest payer after Medicaid was instituted in 1965 because, among other things, there were so many people who couldn't afford medicine, especially the elderly, and the cost of medicine were climbing. The Medicare change had economic consequences to physicians. Kickbacks were always prohibited, but there were now rules about owning diagnostic devices. My mother was a physician, and she had an X-ray in her office. She ran it herself. I knew how to run an X-ray when I was about 12 years old. Now, can you still own CT scans and MRIs? It's not so easy. What about optical shops and physical therapy studios? Can you own an operating suite? Can you have a partnership in it? What about a hospital? How about owning insurance companies and HMOs? In the 1990s, many physicians did very well by setting up HMOs. The restrictive legislation is part of the cost containment, which was instituted by restricting care using gatekeepers, rationing, and other forms of legislation along the British and Canadian models. In case you've never seen it, the photograph is very famous. It's Lyndon Johnson signing Medicare with Truman at his side in 1965. Well, there were problems in politics and public perceptions of medicine and medical advances, and this is called blowback. The slide shows the cost of medical care escalating between 1971 and 2004. It was perceived that physicians were benefited and patients suffered. Remember capitalism? Patients were being exploited. That was the language that we're using. And if you think physicians were seen as bad, the pharmaceutical companies were seen to be ridiculous. And the same thing is going on today if you hear about the cost of insulin. Also, access to healthcare was dwindling. Healthcare was impoverishing the public and companies like Chrysler. Strong forces were pushing for a single-payer system. Nobody spoke for the patient. And it was argued consolidation across industry segments was not necessarily good for the consumer. New models of innovation arose, and innovation financing was re-examined. Before this, large companies paid for innovation, and there was a lot of philanthropy. All you need to do is to look at the hospitals, to look at the wards, to look at the names, and you'll see that the laboratories all had names of famous people on them. Successful, highly valued innovation in healthcare technology was very important. Soon, risk capital became available in return for shared equity ownership in the enterprise. Large companies began distributing. Small companies innovated. Research and academic institutions sought to share in profits from innovation. And public-private partnerships emerged, even in as hallowed a place as the NIH. an inflection period began between 1975 and 1980. Biotechnology began to flourish. There was a rule that money that was given by the government to fund research could not be exploited for commercial purposes. In 1980, the passage of the Bayh-Dole Act allowed federal contractors, including people who got money from grants, to have ownership of inventions that they made with federal fundings. And they could also get exclusive licenses to inventions that were owned by the federal government. This opened the door to biotechnology. In 1975, Amgen was founded, and that led to a growth in venture capital investments in the biotechnology and biomedical arena, the establishment of innumerable companies, a flourishing spirit of entrepreneurship, and a change in the ethos of medicine. Within 15 years, maybe even less, great to have grants, wonderful to be a professor, fantastic to have tenure, but if you didn't have a company, you hadn't quite made it yet. And so founding a for-profit company became a legitimate goal of academic physicians and researchers. And that became incorporated into the ideal of medical entrepreneurship. Biomedical entrepreneurship as a field followed closely. It's welcomed by the investors. First, you had fusion across subjects: biotech materials, genetics, biomedical engineering, informatics, analytics, recombinant technologies and manufacturing, genomics and genetics, immunology, molecular pharmacology, prosthetics, neuromodulation, smart devices, radiation biology, space medicine, the Internet of Things. New and old diseases became the target. The big ones, diabetes, heart failure, atherosclerosis, blood pressure, and stroke, those are the big ones in America. But also arthritis, diseases of aging, beginning to look at Alzheimer's, dementia generally, trauma, and epidemics. And you begin to see the literature. You know the rule: if you want to see what's happening in the world, read the literature. Within a short time, starting in 1985, you see a ton of meetings and books on how to become an entrepreneur. And places like Stanford and Harvard, MIT have programs in biomedical entrepreneurship. In parallel, practice models continue to evolve in response to perceived, and you can use either the term external threat or existential threat to medicine. Initially, this was driven by anticipated changes under Hillary Clinton in the Clinton administration. There were attempts to regain autonomy and prerogatives by physicians, to reduce not only uncertainty, but interference in the practice of medicine. There were anticipated changes in insurance. People looked for efficiencies and economies of scope and scale through practice roll-ups, when you gather practice and put them together, practice buyouts, hospitals would buy out practices, and new sources of income involving new services. Two examples: one, a return to house calls, and the second, concierge medicine, where rather than paying a fee every time a physician was called, patients would pay a yearly fee and have access to physicians anytime they wanted. The search for new service models was exemplified by concierge medicine, and the shifts continued and expanded during the Obama administration. And these shifts proved open to innovation and refinement. A bunch of things became emphasized: quality of care, data informatics and analytics, cost reduction, of course, preventative care, population care, health maintenance, better understandings of pricing and transparency of pricing, telemedicine, teleradiology, other forms of new healthcare delivery, specialty clinics and specialty hospitals, and then medical tourism, which would encourage people to go places where they could get care for less, because there was focus on what it was that was being offered, and the cost of healthcare in some place like South Africa might be inherently cheaper, but just as good. So what does it take to be a biomedical entrepreneur? I'm going to shift now, and I'm going to talk about you and us and me. What does it take to be an entrepreneur and do this? Well, creativity, certainly. Curiosity, perseverance, because everybody fails. And if you don't fail, then either you don't recognize it or you're not admitting that you failed. I failed more times than I can tell you. Organization, ideas, people, management. You have to like people and relationships. This is all about knowing people and putting them together. Comfort with systems. And when I say systems, I mean bits and pieces that have to interlock. You have to be capable of fundraising, asking people for money, and you have to be inured to failure. There has to be a certain amount of elasticity. There's a vision, the ability to orchestrate other people's time, other people's talents, other people's assets to realize the vision, because you can't do it all yourself. You have to articulate the vision that you're pursuing convincingly. You've got to get other people involved. You have to have an understanding of the end point of what you're doing. Call it victory, if you will. How do you know you've succeeded and what is success? And is success attainable? People talk in terms of boiling the ocean. On the one hand, you must want to boil the ocean. On the other hand, you must understand that you're not going to do that right away. You need a sense of strategic vision. You need to be able to build teams. You need to husband resources. You need flexibility and nimbleness. But most importantly, you need a commitment to search for opportunities in society. Successful entrepreneurship is not only about profit, even though profit is key. It's about benefiting society and finding the opportunities to do so. It's the ability to identify critical needs for which society is willing to pay. If nobody pays, an enterprise will not succeed. It includes the ability to identify critical needs in society just in advance of society's realization that they exist. Telemedicine is a wonderful example of that. It's a commitment to serve that need as effectively as possible and to pursue the opportunity beyond the resources controlled. What do you need to do it? Where do you get it? How can you recruit the resources? How can you organize? Then one last thing, which is, I think, underemphasized. If you're going to build a business and be an entrepreneur, you need to be able to have a competitive advantage, something that makes you better than everybody else around you who's trying to do the same thing. And you need to be able to protect your competitive advantage and make it sustainable. Trade secrets help, patents help, but it's more than that. It has to be incorporated into the fabric of the business. So let me leave you with some conclusions. Entrepreneurship in healthcare is a good thing. It creates value by effectively addressing sets of social needs, and in our case, associated with people's health and well-being. It's also necessary in order to drive innovation. And every year or two, we find new reasons why innovation really matters. This year, it's COVID-19. Next year, it'll be something else. There are 4 types of innovation that we need to look at. Scientific discovery that leads to translation. Translation that results in measurable improvements at the bedside. Discovery is knowledge. Translation is at the bedside. The improved delivery of healthcare with an eye to quality, cost, access, comfort, and please don't forget the last word, the dignity of the patient. There are plenty of movies and science fiction books that talk about putting somebody in a machine, pressing a button, and then they're better. And the patients come out miserable because people who are sick want to be cared for. They want to have their hands held. If improved delivery of healthcare allows us to spend more time with patients, as well as has better quality, better outcomes, less cost, and better comfort, we've made it. If it doesn't give them the dignity, I fear it's not going to work. There's also a 4th type of innovation, social innovation to maintain and improve health and well-being on a global level. That may mean what kind of foods we give. That may mean asking whether We want to encourage people in some parts of South America to plant quinoa instead of their native foods. Even though they make more money, their health deteriorates, and they're growing quinoa for an American market. We have a responsibility to go beyond local health. Even though all healthcare is local, there's also global health, and we have to think about it. Entrepreneurial innovation in healthcare has the potential for global reach. If for that reason, if no other, entrepreneurship in healthcare must be driven by a clear moral purpose. We have to have a moral purpose in what we're doing. Pure profit doesn't work. Entrepreneurship with profit, with a clear moral purpose that doesn't encumber what we do, that's something to be admired. And so as you go through your medical training and in your medical practice, I hope perhaps some of these ideas will have been useful. There's nothing wrong with becoming an entrepreneur. There's nothing wrong with saying, what are needs outside of my immediate practice of medicine? How exactly am I going to follow them? And how do I do better for society and seek a reward? And with that, Dr. Bedzo, if I may, I'm happy to take questions if we can do that, and I'm happy to open for discussion. Thank you for your attention.
I would like to say before we do open up for questions, I would say thank you so much for this talk. I think for the Benjamin Rush Institute chapter, it really opens up and introduces us for two views that we need to consider as we continue these sessions. The first is knowing how to change or push healthcare forward necessitates a need to understand how healthcare got to where it is today. A historical context is important to understand where the future can be. The second is that self-interest doesn't have to come at the expense of other interest. When you see a social need and you can push just in advance of realization of that social need, you can do both good and well at the same time. So I did see in the chat that Dr. Galipter would like to ask a question. Dr. Galipter, please feel free to ask a question. Remember, we have only a few minutes, so if you can ask, and then Dr. Dagi will respond.
So I'm Jan Galipter, okay? I'm the course director for microbiology and immunology. I want to thank you for a wonderful, wonderful presentation. If when I grow up, I can speak like you, as clearly as you, as deliberately as you, my students would thank you, okay? And so I appreciate that very much. And you brought up an important subject from so many different angles. And you know, when I was a little kid, you went across the street, you saw your doctor, you paid a few dollars, okay? And literally years ago, you know, when I was a kid, we're talking a long time ago, healthcare was actually more affordable, and you only had insurance for hospitalization and things like that. I'm sure you remember doctors, as soon as insurance came out, doctors began, or many doctors, or a few doctors did it too much. They were billing for everything under the sun, even things that you know, they did not even perform. And a lot like a drug dealer, okay, who gives you the drugs for free and then addicts you to it. That's what I believe happened to the healthcare profession. And that's not what I'm saying. It's what I heard years ago, you know, through the media, that this was happening. And essentially the physicians are now literally captive of the insurance company, and the insurance companies actually direct the treatment. I teach microbiology. I have clinicians come in and say, antibiotic X is the preferred treatment. You have to find out from your hospital which antibiotic they will let you prescribe. Okay, and it all depends upon a financial agreement between the hospital and a drug company. So there are so many things that you pointed out, and so clearly and so eloquently. I just want to thank you so much. It was wonderful, wonderful.
You know, you point out that one of the things that physicians today need to learn is negotiation techniques. Yeah. Because whether it's with colleagues or insurance companies or hospitals or patients, how to negotiate is really important.
Yeah, I'm from Brooklyn, so I tell people bring a baseball bat.
You go to bat for them.
Well,
Jan, thank you for your comment and your question. There was a question in the chat from Mital saying that, or asking if there were any readings you can recommend within the context of this talk. Teo, shortly in a minute or so, if anything comes to mind. Otherwise, I will say that we'll have many other sessions through the Benjamin Rush Institute chapter, and there may be opportunities where either after these sessions or even before the session, we can have readings for people to have a certain context or background to the subject. But Teo, if you have any good recommendations as a closing word,
sure. One of the great books is Paul Starr's book on American medicine. It's really an excellent book. It's not the only one, but it's pretty encyclopedic. The other book, there's a book called Ancient Medicine that speaks about the Greek ideals of physicians. And it's by Asway Temkin. It's worth reading. Just those two for a start.
Yeah, thank you. Those two are they're not quick reads, but thank you. So we're going to be cognizant of time. It is 7 o'clock. I want to thank you, Dr. Dagi, again for a wonderful presentation, and everyone who came and attended. We will have more, but I will say that Dr. Dagi set a very high bar for these sessions, and hopefully we'll be able to keep that level of excellence. So thank you again, and thank you everyone for coming.
Bye-bye.